Hello, good afternoon, everybody from Physio TV. We are live now. I'm handing over the session.
Thank you, sir. Good evening. I, Dr. Siddhant Sawant, would like to welcome everyone on the live webinar series on complex regional pain syndrome. The first Monday of the month of November is celebrated as World Complex Regional Pain Syndrome Awareness Day. CRPS, or Complex Regional Pain Syndrome, as complex as the name sounds, so is the pathology, clinical representation, and treatment of it is. Today, to share some light on this multi-layered topic, we have with us an equally multifaceted specialty. So let's dive right into the webinar, and I'm pleased to welcome our first speaker of the day, Dr. Altaf Warid sir. Dr. Warid is a DNB Ortho Gold medalist with a fellowship in hand and reconstructive upper limb surgery. He is a recipient of Presidential Awardee for the Gold Medal in 2016 by National Board of Examinations as well. Apart from being a hand and an upper limb surgery consultant, his other areas of expertise are trauma, microvascular surgery, peripheral nerve surgeries, to name a few. We are pleased to have you as one of our speakers. Over to you, Dr. Varit.
Yeah, sorry for that. Thank you so much, Dr. Siddhant, for that kind introduction and your kind words. I think this is a really very important topic which we are going to speak on, and most of the times we just neglect it and just don't treat it properly. And as all of us know that CRPS, if not treated on time, it can lead to a disastrous outcome, which which may lead to some permanent disabilities in some patients. So I think today we are going to clear many things about this, and my job will be to give you an overview of this particular thing, and then Dr. Jaspreet and Dr. Priya will maybe do more of talking about it, about the management part. So I think you can see my screen now. Yeah.
Yes, sir.
Okay, good. So I'll just give an overview of about CRPS. So as the word suggests, as you've already told, it's a complex situation. It's a complex regional pain syndrome. So I start off with one case. For example, this is a particular lady, a 53-year-old female, who complains of a severe pain in the wrist. She has a history of casting done before for the lower end radius fracture, which is a very common fracture which we see. Burning pain, severe numbness and tingling. The pain is increased by touching his skin, and her hand is dark red and often swollen, and weakness in the extremity. So you can see that there is disuse osteopenia in the X-ray, and you can see what RSD or what CRPS can actually lead to. There's a gross destruction of the entire bone. The bone is so weak, and apart from that, there are so many autonomic changes. So this particular video again, you can see this lady how she's struggling to do her day-to-day activities, to deal with just lifting up a mobile phone or doing her household work. It becomes it's a lot of pain. So this is what a simple lower end radius fracture or any injury to the upper limb can lead to. And we as an orthopedic surgeons have to be aware of this condition, have to refer such patients as early as possible to the physiotherapist, to the pain specialist people, and so that the timely intervention is taken. This is again, you can see her X-ray. There's a lower end radius fracture which is obvious, which is healed, but you can see the disused osteoporosis and osteopenia rather in this whole region. And it takes years together to get this bone stock back if it is not dealt on time correctly. correctly. So by definition, if we see, it's a continuous pain in a portion of an extremity after trauma, which may include fracture but does not involve a major nerve associated with sympathetic hyperactivity. So there are many definitions. I think that is not very important here, but the important thing is to understand what actually happens. So, what does complex mean? It's varied and dynamic clinical presentation. Regional is non-dermatomal distribution of the symptoms. So, like we see in radicular pain, there's a particular pattern of pain, and we can diagnose that this is coming from the neck. This is a radicular pain of the nerve roots. But in CRPS, it'll be a non-dermatomal. So it'll be a random kind of a pain, which is not correlating with something what is happening in the neck, and pain will be, of course, out of proportion of the injury of the inciting event. Like when you examine such a patient, you touch, there is hyperalgesia. So there's out of proportion of pain is there. So it's a constellation of symptoms basically and signs. So I think most of the times, as an orthopedic surgeons, we do miss these in early stages, and neglect them, and then later on they end up into late stages, and then it becomes difficult to treat. So, brief historical perspective that during the American Civil War in 1864, it was Silas Michel observed a chronic pain syndrome in soldiers who suffered traumatic injury. So it goes back to 1864. So he described this syndrome using the term causalgia. So that was way back in 1864. Again, we know the other name of this is Sudeck's dystrophy. So it was in 20th century, Paul Sudeck had diagnosed this, and because of the inflammatory irritation which involves nutritional problems and in consequence a resorption of the bone. So that's how he explained then why does the bone resorption happens in such conditions. Again in 1917, so this is again way back. It was there was a French surgeon named René Leric implicated that the sympathetic nervous system in causalgia. So he treated these patients with surgical sympathectomy. So in early 90s, this was treated with surgery with surgical sympathectomy. So in 1950s, John Bonica introduced the phrase reflex sympathetic dystrophy. So we all know that there are many terms. So I've put on the list of many terms which we use to diagnose these as Sudeck dystrophy, post-traumatic. They call it CRPS, reflex sympathetic dystrophy, so on and so forth. I think this is a very important slide because this gives us an idea about the incidence is around 5 per 1 lakh in a year. So women are affected more, that is 80%, and 60% occurs in the upper extremities, while as 40% in the lower extremities. So incidence after a fracture is 16 to 46%, which is pretty wide range. Strain or sprain maybe 10 to 29%. Post surgery 3 to 24%. Again, very wide range, not very significant. And contusion or crush injury maybe 8 to 18%. So this gives us a fair idea like how commonly we can deal with them, or where we expect this to happen. So it's very common in females and upper limbs. It's very common. So we hardly see it in males, although it is there, but females somehow it's more common. So there is no correlation between the severity of trauma and degree of CRPS. Again, a very important point, because it's not that there's a very bad fracture or a crush injury or something and they will end up in CRPS. Sometimes a very minor contusion, a sprain, can have a very bad CRPS. So that is what we see. No psychological factor predisposing for CRPS has been identified as of now, but it is definitely considered that there is some consideration of that. So over 80% of these patients had stressful life events close to the time of the diagnosis. So that relation, of course, is there, but it has not been identified as such. So two types of CRPS basically on the presence of nerve injury. That's type 1 and type 2. Type 1 often involves only one limb with pain, minor edema after a period of immobilization, and type 2 is presence of a known injury to the nerve. So that's how we divide it into type 1 and 2. I think this one is an important slide again. How do we classify this? The Langford and Evans stages. So there's actually acute, subacute, and chronic. So if we go to acute, that means 0 to 3 months, there's burning, swelling, warmth, hyperesthesia, cold intolerance, joint stiffness. The X-rays looks normal. That will be positive on a bone scan. So bone scan is one of the investigation which picks up CRPS very early. Although clinical is the best, I think I still suppose say. Subacute is 3 to 12 months, then worsening of pain, cyanosis, stiffness is there, and then skin atrophy. You can see subchondral osteopenia on X-rays, or diffuse osteopenia, I call it. So then chronic is more than 12 months, diminished pain, glossy skin, joint contractures, and extreme osteopenia. Like I had shown the initial couple of X-rays, they probably will fit up in chronic, although they're not more than 12 months. But sometimes in 6 to 8 months, you can have very bad looking X-rays, and also the skin contractures and joint contractures. So basically, there's a triad of symptoms: autonomic, sensory, and motor disturbances together. So that is how it presents. There's distal edema in 80%. Skin temperature changes in around 80%. The hand is initially warm, but then it gradually becomes cold. The skin color changes are there. Sweating is there. Nail and hair changes are there. So all autonomic changes you can find. Also in this picture, you can see there is a gross swelling in the entire arm and forearm. So what we again call is a shoulder hand syndrome sometimes. So the swelling goes up to the arm. There's contracture of the shoulder joint, stiffness, elbow, hand, completely disabling, and it's painful. That is the worst part. uh, Spontaneous pain like burning, aching, throbbing, shooting, or deep pressure pain. With hyperalgesia, as I said earlier, motor changes, they can be weakness, tremors, dystonia, as a part of a clinical presentation or as a result of disuse or painful limb. So that's how they present. So bony changes as osteoporosis, periarticular in a periarticular distribution, joint stiffness in late stages. So patients often have associated psychological disturbances, and I must say, I think they should be timely referred to a proper psychologist who can help them come with overcome with all those psychological disturbances which are there. I don't think I should go into detail of this pathophysiology because that is not the idea. We should more focus on the treatment of it. Two main hypotheses we all know about it. There's a neurotraumatic or neurovascular hypothesis they have been put up, which leads to the maybe Jaspreet can also put some light on this later on about the pathophysiology of developing CRPS. So diagnostic criteria of CRPS again very important. I think this is the point where we should put a more focus on then how to diagnose this at a particular time, because we do any surgery or we put a plaster and we expect some stiffness, some pain in that patient when we remove. Maybe at 3 weeks or 1 month we are removing some cast, or at 2 weeks of a surgery we expect some stiffness to be there. But at the same time we have to keep this thing in mind that this should not be CRPS. The patient should not be going into CRPS, or this is the normal stiffness which we expect at after some particular time of immobilization. So that is again, that is thing. So we have to be very careful at that particular point of time. So presence of any initiating cause of immobilization, continuing pain, allodynia, with pain disproportionate to any event, evidence of edema, skin changes, blood flow, or abnormal pseudomotor activity in the wrist. So if something like this is there, maybe at the end of our any plaster or after a couple of weeks of surgery, we have to be sure that this it's not the CRPS is not setting in. So for that, there's a Budapest criteria by which there are at least three symptoms of these four categories. If they are present, then you probably are dealing with CRPS. So sensory, if there's hyperalgesia, allodynia is when there's more pain on touching the patient. Pain is out of proportion. So it's something like that. Then vasomotor, temperature or skin color changes or asymmetry. Pseudomotor, edema, sweating changes or asymmetry again. And motor, decreased range of motion, weakness, tremor, dystonia, and trophic changes. So if three of these symptoms, if any of these symptoms is present there in that particular patient, so you have to suspect that he may go into um, CRPS. So quickly coming to the diagnostic test, as I told you, X-rays are do pick up CRPS, but in the late stages when you see osteopenia. The earliest investigation, if you want to do, which rarely is done, I've never done this, is a three-phase bone scan if you do, and in stage one or very early also, you can pick up CRPS developing, but absolutely not required to do, because again, as I told you, it's all clinical. It's a clinical diagnosis, and you have to examine that patient, and you'll easily come to that diagnosis. And there are diagnostic tests: synthetic ganglia block, regional intravenous block, pantothenamine infusion test. So Dr. Priya can, I think, talk more about it. So there are diagnostic tests are there. So management, I'll tell you a little about medical management, but most of the management is, I think, probably by the physiotherapists and the pain specialist people. So therapy is directed at managing the signs and symptoms of the disease. It's always a team approach. I think this is the most important thing here. It's a team approach, because an orthopedic surgeon, a physiotherapist, a pain specialist, they all should be seeing the patient together, because you send a patient to a physiotherapist, there is so much of pain that she cannot do anything, or that therapist, he cannot mobilize, or he cannot do any modality because of pain. So if she goes to the pain specialist at the same time, and she manages the pain with some block, maybe stellate ganglion block, any sympathetic blocks, the pain goes down, at the same time the joint is mobilized, the hand wrist is mobilized at the same time, you get the best result. So it is always a triad. It's always a team approach to manage CRPS patients. Because see, if a physiotherapist again tries to put some force and forcefully try to mobilize, that can be counterproductive, and that can worsen the symptoms. So the patient should have a decent pain relief at the same time, while the physiotherapist is doing all the modalities to treat the CRPS. And at the same time, the orthopedic surgeon should always see. So it's always a team approach. So that's how we treat our patients here. We always talk to each other and discuss that how the improvement is, what is going on now. So that's, I think, how it helps, because it's not pretty straightforward, as we all know that it's a complex thing. So then comes the drug therapy, physical therapy. We'll be discussing that in detail. So drugs usually which are used in CRPS, there's a wide list of drugs. If you see the textbooks or literature, there are n number of drugs which have been tried, and there is literature, pros and cons of each. And so it's always you have to pick up what suits for you, what suits best for your patient, and how that patient is responding to that treatment. You may have to change it. Some people do respond to antioxidants like vitamin C, or they very nicely, and some do not. So it's always you have to keep on changing. You have to keep on seeing what is happening, maybe every 2 weekly or every 3 weeks, what is happening. So vitamin C is alendronate, pentolamine, calcitonin, nasal sprays, clonidine, baclofen. All of them have been tried. They all have good results. They all are effective in CRPS, of course, with the physical therapy and everything else. Steroids have a controversial role. Maybe in acute stage you can give to reduce the inflammation, but in chronic phases it's not really recommended to give steroids. But all other drugs which I've mentioned, they have that role. So physical therapy, every early physical therapy is essential to avoid atrophy and contracture. So that's what the point I was trying to make earlier, is that early physical therapy is very important, but at the same time it should not be too painful for that patient, so that it deteriorates. So the pain relief for in that period of time is equally more important. So it reduces pain, it improves the function and coordination. I think Dr. Jaspreet will talk about the more of it, the neurological, recovery, the brain mapping, and all other things. So these patients should take an active role in their care. Sympathetic nerve blocks, again, we will be discussing that can be diagnostic, therapeutic, helping in patients to tolerate physical and occupational therapy. Peripheral nerve stimulators, again, I'll not go into deep. Some TENS have been tried as transcutaneous electrical stimulation or peripheral nerve stimulation, or spinal cord stimulation for that matter, have been tried. Again, Dr. Priya will talk more in detail about it, but there has certainly been some role. Very rarely we find a CRPS because of a nerve entrapment, and for that we do a nerve decompression surgery, maybe a carpal tunnel or ulnar tunnel release or Guyon's canal release or cubital tunnel. So if the nerve entrapment is the cause of CRPS, which is one of the rare indications of doing a surgery in such patients. So most of the studies indicate that patients with early diagnosis and treatment, that is within 6 to 12 months, they have a good outcome. So that is what the literature says. So spontaneous resolution can occur in CRPS if diagnosed early. So if you diagnose them early, you definitely have a good outcome. If you diagnose them late, you are looking for a long time. That takes a longer time. So in summary, I'd like to say that CRPS is a complicated chronic pain syndrome. It's a complex, but you can call it a complicated pain syndrome. A variable clinical presentation and complicated diagnostic criteria. There's vast, as they can present in any way. They have their own set of clinical presentations. So the diagnostic criteria, like a Budapest criteria, which I've told you, if you keep that thing in mind and see what is happening, if there are skin changes, if there is a nail changes, if the sweating or autonomic changes are there, you have to think that this patient is developing CRPS. So that's how you do it. And diagnosis is made on clinical criteria. There's no X-rays, there is no bone scans, there's nothing you can do actually. You just have to diagnose it on clinically and treat it accordingly. Treatment is best managed with multiple approaches, including medicines, interventional procedures, physical therapy, psychological therapy, like I told you earlier. So I think that's about it. Thank you very much. I'll stop sharing my screen. Yeah, Dr. Siddhant?
Yes, sir.
Yes.
So there are two questions basically.
Yeah.
So going with the first one.
Yeah.
So in your in your specialized clinical experience,
Right.
how can one make sure to pick up these signs early? Like, is there any particular sign which is for sure can lead to this complex regional pain syndrome?
Very difficult question and very difficult to diagnose. That is the problem, I think, which we face every time. Whenever we diagnose them, we are already a bit late because that's how it is. Because we expect some kind of swelling, some edema after surgery or after a plaster or any injury to the limb. So it's always, I think, for me, in my personal practice, if I see any skin changes, dilatation of veins, shiny skin, or autonomic changes, in the skin, uh,
Yes.
then that thing strikes me, and that is when I send them quickly to a pain specialist or a physical therapist, and to make sure we start the treatment early. Because even if we start the treatment, maybe medical therapy or physical therapy, that won't harm anything, even if it is not a CRPS, maybe for that thing. So I think that is it. I mean, clinical, because we can't do bone scan or so some fancy investigations in all the patients where we suspect.
Yes, yes, yes. Very correctly said. And so the second question is in two part.
Yeah.
First, is it preventive? A, is CRPS preventive? And B, the osteopenia which you spoke about in CRPS, is it reversible?
Okay, the first question, I'll answer your first question first. So I think it is very much preventive because what where in my practice or when we see in orthopedic setup is most of the upper limb fractures and more commonly in lower end radius fractures. I don't know why. Somehow we see this CRPS developing. That is probably the reason they are plastered most of the time. So immobilization is definitely one of the big stimulus to developing this CRPS. So I don't know whether prolonged immobilization has a direct role or a short immobilization will have less incidence. I'm not sure about that. But definitely, whenever we immobilize a patient, then there are chances of developing. So I think for me, it is early immobilization which definitely prevents it. So we try to not put casts for longer time or rather avoid them. If you're doing a surgery, then definitely you are not putting a plaster. You are to mobilize the next day. And I have not seen a patient developing CRPS probably who has not been in a plaster. For me, it's always been in a patient who was in some kind of an immobilization. Very rarely, sometimes it is otherwise. So that is, I think, immobilization or early mobilization. Not immobilizing for a long time, that may prevent it. I don't know how literature supports it, but that in my personal practice. And I think the second part of your question is osteopenia. It definitely reverses. It definitely does. I have seen the follow-up of all the patients. At one point of time, it looks very bad, but it takes not months, I must say years, to get back when it is very bad. So it may take 6 to 8 months to a year for that bone density to become normal. Usually, when it settles, we usually give teriparatide, which is a parathyroid hormone, which stimulates the osteoclast, and there's a good bone formation, and that has proven to be very effective when we are dealing with that osteopenia. So I think that is reversible, yeah, but it takes long time.
Okay. 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 Fine. Thank you so much, sir. Thank you so much.
Yeah, thank you.
Yes. Thank you, sir, for the informative session and putting this giant in a nutshell for us. It was a difficult task that you have achieved. Thank you so much. Our next speaker for the day, Dr. Priya Buddhadev Rathi, is the Director of Chronic Pain Service at Asian Orthospine Clinic, Aund. She is a visiting consultant at Sancheti Hospital and is specialized in ultrasonographic fluoroscopy guided interventional pain management. Her areas of interest are neuropathic and musculoskeletal myofascial pain. She holds a fellowship in chronic pain medicine from Ashirvad Institute of Pain Management and Research, Mumbai, as well as from Tata Memorial Hospital, Mumbai. It's an honor to hear from you, ma'am. Over to you, Dr. Rathi.
I think you need to unmute, or you're already unmuted.
Yeah. Am I audible now?
Yes, ma'am. If possible, you can come a bit close to the mic and you can switch on the video, please.
Just a minute. My video is already on. Am I not visible? You are not
Yes, ma'am.
visible.
Yes, ma'am. Yes, ma'am. You're audible.
But my video is already on.
Yes, ma'am. Okay.
Am I visible now?
Yes, yes, yes. Ma'am, you can start.
Okay. Hi, good afternoon, everyone. Today I'm going to talk about recent advances in management of CRPS. We have been knowing these conditions from more than 150 years, but still there is no short solution which will say that, okay, yes, this treatment is going to work for CRPS. We have multiple treatments and they work in a different manner in different patients. So it's a nightmare for doctors as well as patients, because pain can be so bad that daily activities of daily living can become impossible. So we are dealing with this medical mystery for more than 150 years, and now it's a high time that we get the simple solution for this complex problem. As clearly said by H.L. Mencken, that explanation do exist and they have existed for all the time. There is always a well-known solution to every human problem. It could be neat, plausible, and wrong. So now we may have neat solution for CRPS with multimodal uh, regime of management. So for CRPS, we need to follow certain basic guidelines of management. One is start treatment immediately as soon as it is suspected. We need to have very high level of suspicion for CRPS. Treatment should be directed towards the restoration of the function. And interdisciplinary and multimodal treatment is the solution of CRPS management. Why I'm saying this is because if we include multiple modalities, what final benefit we get is much more than the individual benefit. During recent years, there have been paradigm change in understanding of the pathophysiology of CRPS. What change is there is myofascial involvement is the primary pathology of CRPS. This is what is being identified now. Pain, sensory, pseudomotor and vasomotor symptoms, Those are all secondary to motor involvement, and they have all acted as red herrings which have diverted our attention away from the motor issues. So what motor pathology lies is co-contraction of agonist as well as antagonistic muscles. Ideally, when I flex my fingers, flexor should contract and extensor should relax. This is called as reciprocal inhibition. But in CRPS, this reciprocal inhibition is lost, and when the patient of CRPS tries to move the fingers, there is simultaneous activation of agonist as well as antagonistic muscles, which leads to friction at tenosynovial junction, and this friction further leads to inflammation. This inflammation presents itself in the form of pain, rubor, calor, and dolor. And this further leads to central and peripheral sensitization because pain remains untreated for longer duration. Now, this is a patient of CRPS. You can see normal right hand and CRPS of left upper extremity after fracture radius. You can note the glistening and glistening skin and swelling of the left upper extremity. When we see under ultrasound, we had kept the ultrasound probe on the dorsum of the hand. What we are able to see is the tendons which are floating in the lot of synovial fluid, as against the normal hand where tendon is not surrounded by any synovial fluid or maybe very little synovial fluid. So musculoskeletal ultrasound confirms all the surmises of co-contraction theory, and tenosynovitis of digital tendons is visible on musculoskeletal ultrasound. Now this is how the normal muscle looks like. Here the probe was kept 5 cm below the elbow line on the flexor aspect. What you can see here is the bony shadow of radius and ulna, the nicely demarcated muscles, that is pronator teres, flexor carpi radialis, flexor digitorum profundus, superficialis, etc. But in CRPS affected arm, you cannot demarcate any muscle tissue. It all appears as single fibrotic tissue. This is this ultrasound picture of 26-year-old girl who had metacarpal fracture 18 months before and landed up with CRPS. You can see clinically she is not able to flex the fingers properly. After 1 month of ultrasound-guided dry needling, she had shown improvement in ultrasound picture as well as clinically. So this is how the ultrasound looked like after 1 month of dry needling. The muscle margins have come back. Even the muscle bulk is more. Clinically, what you can see is patient is able to make the fist. So this is how classical posture of CRPS changes with ultrasound-guided dry needling. Here, on day 3, patient is not able to flex the fingers at all. On day 7, there is slight flexion at metacarpophalangeal joint. On day 12, patient is able to make fist but not completely. On day 22, after around 8 to 10 sessions of dry needling, you can see normal hand is producing 8 psi of pressure on dynamometer, but the CRPS hand is generating 4 psi pressure on dynamometer, as against it was 0 on day 17. This is another patient who had undergone 4 surgeries for fracture radius. Revision surgeries were done. Last surgery was 4 years back. He developed pain in the wrist, the elbows, and at the surgical site and at the shoulder 1 year back. He presented to me in very late stage. He had muscle atrophy at the deltoid. He presented with restricted range of motion at all the joints. You can notice the abduction at shoulder joint was maybe around 80 degrees, but after few sessions of dry needling, he is able to go beyond 160 degrees. Now this ultrasound-guided dry needling, it works in a way that after around 2 to 3 sessions of needling, there is reduction of wrist pain, the sleep disturbances are improved, swelling and warmth is gone, but movement-related pain still continues, and within 15 days, we do not see any tremors and dystonia, and after 30 to 45 days, a range of motion improvement is clearly seen. Now, what sympathetic nerve blocks? They have been the mainstay of treatment for CRPS management. We use stellate ganglion blocks for upper extremity, lumbar sympathetic blocks for lower extremity. These blocks work very well for acute CRPS, but in chronic stages where there is a lot of atrophy, when there is no swelling of the hand, that does not sympathetic nerve block do not work in those cases. There is no good data on long-term efficacy of these blocks, and usually the results are temporary. We may have to repeat the blocks again and again, and the relationship between CRPS and sympathetic nervous system is not very straightforward. What I mean by this is, whenever I give sympathetic nerve block to to the patient at one point of time, it may work, and at another point of time, it may not work. So this is how the stellate ganglion and lumbar sympathetic plexus block is being performed under ultrasound, under C-arm guidance. Continuous peripheral nerve block is good for pain relief. It provides early mobilization and rapid recovery is possible. But remember, it does not have any impact on disability. Here you can see the catheter being passed under the skin near brachial plexus, and we give continuous local anesthetic drug through that in the catheter. The spinal cord stimulators, they have been talked about CRPS in recent years, wherein we put the electrodes in epidural space, and those electrodes are connected to the pulse generator, and here the painful sensations are being replaced by tingling sensation or any other non-painful stimulus, non-painful sensations. But spinal cord stimulators have their own disadvantages. Like the PHYSIO study says that around 25 to 50% of the patients develop complications who require further surgery. And it is said that spinal cord stimulators reduce the pain and improve the quality of life in many patients for up to 2 years, but it did not improve the function for up to 2 years. From 3 years after implantation, there was no difference between those who had it implanted and those who did not have it implanted. Again, we can have many complications related to spinal cord stimulator, like dislodgement of the lids, breaking of the lids, or infection, or redo surgeries may be required in spinal cord stimulators. Now, the activities which are usually essential for daily life are impossible at the first visit, but after multimodal treatment regime, like we give sympathetic nerve blocks in acute stages, and we put in the catheters, continuous nerve block catheter, and then do the dry needling and physiotherapy. These activities become possible after the treatment regime. We use medications along with the interventions. Commonly used medications are gabapentin, pregabalin, duloxetine, amitriptyline, and nortriptyline. Here, in chronic stages, paracetamol, non-steroidal anti-inflammatory drugs, and steroids are usually not recommended. Ketamine, it's an NMDA blocker. NMDA receptors are upregulated in CRPS. So, ketamine is supposed to be useful in CRPS, and it is useful if used along with other modalities. As a single agent, it does not work. Opioids are not to be used in CRPS. Why I'm saying this is because opioids leads to glial cell activation, and which further leads to neurogenic inflammation, and neurogenic inflammation is considered to be the pathology of CRPS. Other medications are naltrexone, bisphosphonates, vitamin C, alpha lipoic acid, and N-acetylcysteine. So this is how there have been publications in CRPS where there has been complete reversal of CRPS even in chronic stages with the help of multimodal treatment regime like sympathetic blocks, peripheral nerve blocks, and ultrasound-guided dry needling. Thank you.
Thank you, ma'am. Ma'am, there are basically two questions for you to answer. The first one, can in short you explain the mechanism? How does the ultrasound-guided dry needling works?
See, as I explained previously, that what we see in the patients, there has been a lot of motor component in CRPS. So with that surmise, we have been doing ultrasound-guided dry needling for those patients, and it works by multiple mechanisms. The mechanisms are not being proved till yet, but there have been theories how does it work. So one of the thing is release of endogenous opioids, inhibition of the ascending pathways, and activation of the inhibitory interneurons. And anti-inflammatory effect also needling has. So with all the ways, overall it has analgesic effect, and it reverses the motor disability also.
Okay. And ma'am, the second question is, out of all the mentioned techniques, in your very personal clinical experience, which one do you think so tops the list?
It's very difficult to say because I have been mainly focusing on multimodal treatment regime. So we use drugs also. If patient has presented to us in very acute stage, then I put in sympathetic nerve block also. And physiotherapy also goes hand in hand. And dry needling is the basic pathology. So basic treatment. So I would say dry needling tops for me.
Yes. Okay. Fine. Thank you so much, ma'am. That was indeed a great session. I'm sure our viewers have got a different perspective with these advances coming up in this field. So we are glad that we had you also as one of our specialists talking about it. Our next, moving on, our next speaker, Dr. Jaspreet Kaur Talwar, is a gold medalist at Maharashtra University of Health Sciences. Completing her graduation and post-graduation from PT School and Center, State GS Medical College, KM Hospital, Mumbai, ma'am excels in treating patients with brachial plexus injury and tendon repairs. Working in closed knit with respected surgeons like Dr. Abhijit Vaigaonkar, our young and dynamic speaker has traveled a long distance in a short span. Over to you, Dr. Talwar.
Unmute.
Thank you. Today we'll be talking about recent advances in rehabilitation of CRPS. Like sir has already talked about the history, it was first discovered in 1864. Right now, you all know about the pathophysiology, you all know about what are the types of CRPS and how it can be managed by pain, like by specialists like pain management anesthetists. Now, with physiotherapy point of view, we have so many options. What should you go for? Electrotherapy, exercises, desensitization, mirror therapy. How would you decide that? First, we need to understand the pathophysiology for the same. Persistent chronic pain can cause reorganization of primary, secondary sensory cortex as well as motor cortex of the brain. Hand has a very big representation on the homunculus. Due to persistent chronic pain, this cortical representation can get reduced, and this can cause body perception disturbance. That means the patient might feel that the hand is not his own. There is difference in size and shape of the hand, the spatial perception of the hand. It can also alter the cortical processing. That is the sensory motor incoherence can occur. Every treatment given to a CRPS patient should be individualized. You cannot use a common protocol for each patient because every patient might have a different intensity of pain, different intensity of sensory motor disturbances and stiffness. Now, let's go back to how conventionally we treat any patient who comes to physiotherapy. We go for a modality like IFT, TENS, stimulator, or we go for fermentations like hot, cold, contrast bath, or exercises. Now, when it comes to fermentation, what would you choose? Cold, hot, or contrast bath? Now, cold has very poor evidence at treating or improving the condition of CRPS patients. It tends to, if sudden extreme temperature like cold given to a CRPS patient, it can cause a reflex sympathetic outflow. Hot fermentation works in CRPS, but only in chronic stages when you want to improve the pliability of the soft tissues like ligaments, muscles, capsule, and you want to improve the range of motion. In the acute phase of CRPS, contrast path has strong evidence to reduce the swelling, and alternate vasoconstriction and vasodilation also improves the circulation and reduces edema. Electrotherapy machines, all these machines mentioned over here, do not have any strong evidence supporting them to reduce pain in CRPS. There are few articles that say that TENS and muscle stimulator do help in CRPS, but that is again questionable. Exercises, stress loading exercises like scrubbing, carrying, which has excessive maximum isometric contraction and reduced movement, have proved beneficial in cases with CRPS. As you can see over here, this is an instrument called dystrophile. This gives a resistance between the dystrophile and the surface it's placed on. You can adjust the resistance. The patient needs to press or load from the top and move it in various directions, which is similar to scrubbing. And this causes isometric contractions. And carrying, like initially you can start with a light load or weight, approximately half kg in the hand, and then go to taking more weight in the hand and moving around. This again causes strong isometric contraction with less movement. Aerobic training has evidence that says it releases endorphins and epinephrine, which helps in breaking the chronic pain cycle. Functional training, functional goal-oriented training and TNF patterns, they help in improving CRPS patients' recovery at a faster rate. Like suppose if you tell a patient that you have to remove an object from a top shelf or reach to an object, that will give you a better result than asking the patient just to flex the shoulder. Mirror therapy. Now we come to working on reorganizing the sensory motor cortex that was affected so that we can reduce the sensation of pain and can work more towards the function. Mirror therapy is used in such a way that it creates an illusion of a good hand where your affected hand is. Your unaffected hand is kept in front of the mirror and affected hand is concealed behind the mirror, and the patient is asked to see inside on the mirror. When the patient sees on the mirror and does the movement with the unaffected hand, he perceives that he's doing the movement. There's a good movement by the affected hand as well. It sort of improves the attention to the limb, ownership, and reduces the sensory motor incongruence. This also helps in activating the mirror neurons. Graded motor imagery is also used. This has 3 stages. First is laterality, that is left-right discrimination. There are flashcards with different hand position, different hands, right and left hand, kept in front of the patient, and they are asked to recognize which hand it is. Patients suffering from CRPS take more time than the general population to recognize this side of the hand. This helps in improving the mapping on the cerebral cortex. Once the patient is able to do this, you go to explicit motor imagery. You ask the patient to imagine or think that they are placing their affected hand in the same position as placed on the flashcard. This helps in activating the mirror neurons. Mirror neurons, what do is they activate the pathways even when you're thinking or you're imagining a movement, hence improving the pathways and cortical reorganization of the brain. Followed by mirror therapy. Mirror therapy even strengthens these pathways. So this graded motor imagery is beneficial in the acute phases. It has given great results in reducing pain in the acute phases when a patient has a lot of inhibition to move the limb due to pain, but can imagine and recruit the pathways just by observing and imagining. Somatosensory rehabilitation. It is a psychophysical evaluation where you define the territory that is painful to touch, and it can be formed by a peripheral nerve or it cannot be formed. You have to decide a territory, and then you have to avoid all the movements, all the sensation or the sensitization mechanisms over that area that causes pain. Then you start with counterbalance, that is counter stimulation. You start with tactile or vibratory stimulation, which are soothing, and that tends to reduce the sensitization of the same territory of the skin. We'll go to exposure therapy. Exposure therapy is very much related to chronic pain, because as the pain gets chronic, there is pain-related anxiety and fear that tends to develop. This anxiety and fear stays even when the underlying pathophysiology is resolved. So you have to start screening the patient for the activities that are fear limited and not physiologically limited. Suppose, just for an example, if a patient fears that if he goes across, lean across, stretch the arm and lift the bottle, he might have pain. So you understood, you analyze this activity, then you educate the patient. You ask the patient to go across and try to lift that bottle. If the patient is getting pain, you will stop the movement and analyze it and then find a solution for the pain. You take the patient into confidence and ask the patient to stimulate the same movement that is causing fear. Once the patient is able to do the movement without any pain, you disconfirm the fear, saying that how he was able to perform a movement even with more ease than what he thought. Like that, you have to reassess all the activities that might be limited by fear and not by physiology. Virtual reality is an upcoming thing that is really beneficial for rehabilitation of CRPS. Here, a sensor glove is put on a non-affected hand, and you can see on the screen this glove, when represented, or the non-affected hand is represented as an affected hand on the affected side on the screen. And when the person is trying to do the activity with non-affected hand, the affected hand on the screen is doing the activity. It is very similar to mirror therapy. It is reward based and stages. As you climb up the stages, there are activities. There is a lot of positive reinforcement that indulges the patient to do this more and more. Along with so many rehabilitative therapies, from a physio point of view, we also need psychological rehabilitation for our patients. Cognitive behavioral therapy, acceptance, commitment therapy, mindfulness, relaxation techniques, all this have also played an important role in relaxing the muscles of the patient, in reducing pain, and making the patient more comfortable for doing exercises. These are the references. You can go back and read for more details. And this Monday is World Awareness Day for CRPS RSD. Is the Color the World Orange Day. So I would request you all to wear orange on that day and support the patients suffering from CRPS, because they are in pain, but they are strong. Thank you. Any questions?
Thank you, ma'am. Okay, going with the questions, you have two questions basically. So the first question is, apart from the surgeons, as a physical therapist, when do you refer to a patient for pain management? What are your criteria that you look for that this patient is an ideal patient for reference to pain management, if it's not done already?
So when a patient comes to us with CRPS, you have to check the intensity of sensitivity in the patient. How much pain the patient is having, how difficult are the movements. If that is something that you can manage with your graded motor imagery or mirror therapy, virtual imagery, then you can continue with physical therapy. If The pain is something that is not manageable at your level. The pain is restricting your rehabilitation. You're not able to achieve your functional goals because of the pain. You should be upfront and refer the patient to pain specialist so that the pain does not really forms a hindrance. Because if not managed the patient well in the early phase, the patient will land up with stiffness.
Yes.
And that will be difficult for all of us to manage. If a patient develops stiffness, has pain, then it is a headache for everyone.
Yes. True. Very correctly. Thank you. And the second question is, now in the starting, Dr. Varid sir also mentioned that immobilization might be one of the reasons for it, a prolonged immobilization. So, in your clinical expertise, have you come across that splinting during the treatment? Does it have any specific role to play in this?
So splinting, you mean to ask whether splinting will be beneficial or not in CRPS, right?
Yes, exactly.
So in acute phases, splinting is absolutely no. A patient has a lot of hypersensitivity. It has allodynia. It has swelling. If you enclose it and compress it in a position with a splint, it is going to exacerbate the symptoms. But in chronic phase, when you want to lengthen the tissue, suppose if it is 8 months down the lane, 6 months down the lane, when the patient has stiffness, has gone into a flexor deformity, and you want to gradually get the extension, that time you should opt for splinting. But again, always check for pain intensity. Always check for allodynia or hypersensitivity. The patient should not rebound back with more pain.
Yes. Okay. Thank you so much, ma'am. Now, the last question is for all our three esteemed speakers. We have spoken a lot today about complex regional pain syndrome. And one of the criteria or one of the points that repeatedly came up was early diagnosis of this condition. So, in your personal opinions and your clinical experiences, what measures can we start taking, since there are a lot of therapists and a lot of medical, paramedical personnel listening to it? Is there specific things that we can do for awareness of this condition? The steps that we can take for it?
Can I take that? Jaspreet can stop sharing the screen, I think, so that we can see the panelists.
Yes.
Yeah. So anyone can take that. I think Jaspreet can take that question.
Okay. So you have to be very vigilant. You have any hand injury, you have to be vigilant about the fact that you are not feeling excessively. See, after a hand injury, after a fracture, there is immobilization, everything is normal. Okay, you are going to get swelling, you are going to get pain. That is a very natural, normal phenomena. But the moment you feel that there is something different, the pain that feels on touch, that is not normal. Okay, the swelling that stays and stays, it is always red. Anything you touch, even the cloth going over it, even the change in surrounding, the air feels painful. That is something you need to be very quick at finding out and going to your doctor and saying that, yes, now this is something different. This is not that happens every time. So you have to monitor your pain very well, is what I think.
Okay. And can we have Dr. Varid or Dr. Priya?
I think I would completely agree what Jaspreet has just told. In our orthopedic residency, we are always taught sometimes, we know about compartment syndrome, like it's a medical emergency, and you have to, immediately treat that thing. And one of the signs to diagnose the compartment syndrome was pain out of proportionate of the injury. For example, any patient has a tibia fracture, a tibia fibula fracture. We know what amount of pain that patient is having, and we expect him to be in that pain. But sometimes they are in a pain which is really out of proportion, and that worries us, and there's a compartment syndrome developing. I think similar kind of an approach maybe by orthopedic surgeons when we see our post-op patients or plaster or for any injury. If they are behaving not in a normal way, their pain sensitivity is very high, it is out of proportionate to what it should be, and hypersensitivity, as Dr. Jaspreet has told, I think that is that what is happening. And if we can send this message across to all orthopedic surgeons who are watching and all the physiotherapists and other staff. So that will be, I think, that will be really good.
Dr. Priya, would you like to opine?
See, basically, early diagnosis is always being focused upon. And for early diagnosis, whatever Budapest criteria are being laid down, many of the patients do not satisfy those criteria. So the another category has been laid, that is CRPS, which is not otherwise specified. So we need not have to stick on the criteria. Clinically, we should judge that, as Jaspreet has said, that pain that is disproportionate to the inciting event. That is the main criteria, and we may not see vasomotor symptoms or pseudomotor symptoms in all the patients at one point of time. Usually, the grading of CRPS also it varies. It is not book-like picture. So we have to change our views from patient to patient rather than going by book picture.
Yes.
Yeah,
Yes,
exactly.
yes.
And to add to that, I think we have to change the treatment of patient to patient. It can't be a blanket treatment for everybody. Absolutely different for any patient. You know what works for that particular patient.
Okay. 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 Great. Thank you so much, everyone. So today, indeed, we learned that however numbing and chronic the pain might be, there are always healing hands around you. Our esteemed speakers are torchbearers of same. I take this opportunity to thank Dr. Varit, Dr. Rathi, and Dr. Talwar for sharing their expertise and clinical experiences with us on complex regional pain syndrome. Apart from that, a heartfelt gratitude to our driving force of our institute and our founder president, Dr. K.H. Sancheti sir, our ever-inspiring chairman, Dr. Parag Sancheti sir, and our dynamic executive director, Mrs. Manisha Sanghvi ma'am, and our always encouraging principal, Dr. Vivek Kulkarni sir, for giving us this platform. I thank our Physio TV team, Dr. Ashok Sham, Mr. Rahul Chaube, Dr. Apur Shimpi, Dr. Neeraj Athavle, Dr. Manish Ray, Dr. Amruta Poddar, and all the members of Physio TV. Lastly, I express my gratitude to our attendees who have played a vital role for making this webinar a successful venture, and looking forward for your support in the upcoming webinars as well. I, Dr. Siddhant Sawant, signing off. Stay safe and take care of yourself and your dear ones. Thank you, everyone.
Thank you.
Okay.
Yeah. Yes, sir.
Yeah, so we are live. So good evening. It's indeed a great pleasure to welcome all of you for this webinar, a joint webinar of Asia Pacific Arthroplasty Society and OrthoTV along with the Sancheti Institute. So it's a great moment to see all of you. I take pleasure in welcoming Professor Thorsten Gerke, who's going to moderate the session, Dr. Amar Ranawat from HSS New York, Vijay Bose from Chennai, India, and along with a great panel, Dr. Mahesh Kulkarni, Dr. Rajiv Joshi, and my father, Dr. KHS. And we also have the president of Asia Pacific Arthroplasty Society, president of Asia Pacific Knee Society, and ASIA, Dr. Professor Nicholas Budiparma join us. So over to Dr. Nicholas to say a few words, and then we hand it over to the coordinator for today, Sahil. Over to Nicholas.
Thank you, Parag. Good evening and afternoons in Europe. Welcome to today's webinar. It is collaborations between the APAS and the Sancheti Institute and OrthoTV. And thanks to Professor Parag Sancheti that make it happen. I think he's the pioneer in broadcasting the webinar all over Asia Pacific. And today's webinar is on bearing surface in replacements. And the question is now, which bearing surface is to choose and why? We are going to focus on discussions on ceramic or ceramic and poly. I think the discussions is about bearing surfaces very crucial. Since a few years ago, we know that the world was shocked by litigations pertaining to metal on metal bearing. And the argue was that metal on metal is the only material for long survivorship, especially for the young surgeons. And now the question is whether ceramic can replace metal, and whether ceramic on ceramic has a better survival rate than ceramic on poly. We are happy today to have my good friend here, Professor Thorsten Gerke from Endo Clinic, who's going to moderate this session, since I think he does the most revisions hip in the world, I think, because especially PGI and width bearing that he will suggest us. And we have the faculty here, my brother Amar Ranawat. Know that his buddy is in New York, but I almost see him every month in Asia Pacific to give all this to educate all the surgeons here. So, and also my good friend here, VJ is also here, and they're going to have a debate on which bearing will have the better survival rate, and especially for the young surgeons. So for without further delay, let's start the debate. I hand it over to the moderator.
Yeah. So good evening to all our viewers from the East, and good morning to all our viewers from the West. I'll just share my screen in a minute. So today's webinar is our second webinar in the APAS HIP series. The previous one we did was on anterior versus posterior approach for total hip arthroplasty. And today's webinar is about the choice of bearing surface for total hip arthroplasty in young adults. So we have Dr. Amar Ranawat, who will be speaking for ceramic on poly, and Dr. Vijay Bose, who will be speaking for ceramic on ceramic. So Dr. Amar Ranawat completed his medical degree from the Weill Cornell Medical College, and thereafter completed his residency from the Hospital for Special Surgery in New York. Thereafter, he did his fellowship from the Lenox Hill Hospital under his father, Dr. Chitranjan Ranawat. He was awarded the Hip Society British Traveling Fellowship and the OREF grant for MRI in early detection of particle disease following total hip arthroplasty. He is a reviewer with esteemed journals like CORR, JOA, the HSS Journal, and Current Orthopaedic Practice. He's received the James Rand Award for the most outstanding paper in knee surgery and the Chief Resident's Special Award as well. His areas of interest include alternative bearings in the hip and the rotating platform technology in the knee. Dr. Amar Ranawat, we welcome you to today's webinar.
Thank you for having me.
Dr. Vijay Bose is the Joint Director and Consultant Orthopedic Surgeon at the Asian Joint Reconstruction Institute and SRM Institute of Medical Sciences, Chennai. He did his MCH in orthopedics from the University of Liverpool and thereafter completed his FRCS. He's received numerous awards like the Lieutenant Colonel Thayu Munaswamy Gold Medal Award, the Young Achievers Award, the Best Doctor Award from the Tamil Nadu Dr. MGR Medical University, and he was recognized by the Honorable Governor of Tamil Nadu for his exemplary contribution in the field of hip arthroplasty. He's been the past president of the Indian Arthroplasty Association and has also been the fellowship chair for the Indian Society of Hip and Knee Surgeons. Dr. Vijay Bose, we welcome you for today's webinar.
Thanks, Sahil.
Our moderator for today's webinar is Dr. Thorsten Gerke from Germany. He is the Medical Director and Chief Physician for Orthopaedics at the Helios Endo Clinic at Hamburg. His areas of interest include aseptic and septic revision surgery of the hip and knee, and he has done pioneering work in one-stage revision total joint arthroplasty. He's been the past president of the Congress of the North German Orthopedic and Trauma Surgeons Association. He's been a visiting professor in various countries like China, Colombia, the University of Chile, Argentina, and Kuwait. Dr. Thorsten Gerke, we welcome you for our webinar today.
Thank you so much. Hello, everybody.
Our guest faculty includes Dr. Mahesh Kulkarni, who's an arthroplasty surgeon from Pune, and Dr. Nicholas Buddhiparma, who's the president of the Asia Pacific Arthroplasty Society.
Thank you, Sahil.
Our panelists for today are Dr. Rajiv Joshi and myself, and we also welcome our patrons, Dr. K.H. Sancheti and Dr. Parag Sancheti. So I'll hand it over to Dr. Amar Anawat, who's our first speaker, who will be speaking for ceramic on.
Thurston Garke is giving some opening remarks, isn't it?
So we have a prelude to the debate, and Dr. Thorsten Gerke will be giving his introduction to today's topic.
Thank you so much, Sahil, for this very kind introduction. And so what we are, hello everybody. First of all, I'd like to say hello to everybody, and I'm really proud. It's a great honor for me to be part of this wonderful webinar, to be together with all of you again, and in these dark times. So it's always good to meet great friends again, even if it is virtually. At least we see each other, we hear our voices, and so we are, in a certain way, we are together. And great honor for me to be against the moderator of this very interesting session, which is dealing with the debate between ceramic on poly versus ceramic on ceramic, focused on THR for young adults. So I give you two examples of patients from my patients of the last 2 weeks. 2 weeks ago, I operated this young girl, 16 years old, from St. Petersburg. And the question is, what should we do here? 16 years old. Yesterday, I operated another young girl from Moscow, 18 years old. Both of them suffered of aseptic necrosis of the femoral heads due to chemotherapy. And also here is the question, what should we do and what should we use in this kind of patients? What about young patients? There are several studies about young patients where you can see there is, at least in idiopathic arthritis, a difference in between patients of younger than 25 and older of 25. If we go to the registries, here the Norwegian registry, who overlooked about 110 patients in the mean age of 17 years, they reported in this registry a 10-year survival of 70%. And here you can see what kind of bearings they used in their patients. The largest review about patients younger than 30 years probably is this review, which was a mean follow-up of 8.5 years. They concluded that the patients are not necessarily more bad results than older patients. And the uncemented acetabular components that have been shown to have the lowest rates of implant loosening in these youngest patients. And they suggest that all uncemented THAs may outperform in patients younger than 30 years. But nobody is really telling about, or was telling about in these studies, about the bearing of these in these young patients in specific. So here are our main choices: highly cross-linked, vitamin E, ceramic on ceramic, and metal on metal. Some other choices are available on the market, but these are used still quite rarely. If you look at the data from US, you can see a clear rise of ceramic on polyethylene and a decrease of usage in metal on metal, of course, as Nico said already, and in metal on poly. But what about patients, very young patients? Here is a case study, a single case study of a 13 years old boy who received ceramic on ceramic. Another paper from the Mayo Clinic, they reported in very young patients, mean age 16.4 years, a survival rate of 96% with very good outcome and functional results. And another study from France, the same 10-year results in very young patients, about 17 years, about 90.3%. So again, here I tell you what I did 2 weeks ago with a 16 years old girl. I implanted a cementless implant and with ceramic on poly. And yesterday, the same, 18 years old, bilateral hips, also ceramic on poly. And now I'd like my both friends, Amar and Vijay, to give their notes about their opinion of ceramic on poly, or Vijay is going to talk about ceramic on ceramic. I'd like to ask first Amar to give us your view about this topic. Please, Amar.
Thank you, Thorsten. It's great to see all of you. Oops, I got to go to the beginning. And thank you for having me. I really appreciate the opportunity. You can see my slides?
Yes.
Yep.
Great. So I'm going to talk about my clinical experience with using ceramic on poly, the Biolux Delta material against highly crossing polyethylene. The interesting thing about my talk, I won't be quoting other people's data. Everything you'll see will be my own data. I do have to disclose that I have received research support from Ceramtech in the past. So I'm going to make the argument using my data that this is a nearly perfect bearing and it should be used in almost everybody. I think you can always make an exception and you should never close your mind to individual cases, but you need to have some general rules and some guidelines. The first thing I want to mention is Dr. William Harris, who basically developed highly crossing polyethylene, made a statement a few years ago where he said wear rates are now independent of head size. Because that was one of the biggest problems with using polyethylene in the past, is that we knew once you got greater than 28 millimeters in diameter, that your volumetric wear would go very, very high. So the introduction of highly crossing polyethylene allowed us to use larger head sizes. So let's talk about the hot topics in ceramics. There's always a concern for fracture. That's number one. Squeaking, ceramic on ceramic hips. What is the actual wear? Metal ions, trunionosis, dislocation, and infection. These are all issues that come across when you deal with ceramics. Well, let's talk about fractures. The reality is once you get past 28 millimeter heads, which I almost never use, the vast majority of my cases are 32 millimeters in women and 36 millimeters in men. And that's really a function of the size of the acetabulum. I think if you're using highly crossing polyethylene, you want to have around 5 to 6 millimeters of poly thickness. So that really is what determines your head size. But if you look at that, above 32 millimeters, the risk of fracture is negligible. And I'm not really aware of any ceramic fractures greater than 28 millimeters using the Biolux Delta ceramics. It certainly was a problem with the Forte ceramic in the past and other ceramic designs in the past, but the Delta ceramics have been performing exceptionally well. So simply put, in my mind, ceramic head fracture is a non-issue. Squeaking. This is a paper that we published almost 20 years ago now. It showed an incidence of 3.4% of squeaking. And multiple reports have shown that ceramic on ceramic hips will squeak somewhere between 1 to 3%. It doesn't seem to have a long-term clinical effect, but it certainly is socially unacceptable to have a hip that squeaks every time you get up from a chair, for instance. The fact of the matter is ceramic on poly does not squeak. So for me, squeaking is a non-issue as well. So let's start to talk about wear. If you use conventional polyethylene, if you have wear greater than 0.1 millimeters per year, you will get osteolysis and loosening via a histiocytic response. This has been well described and written about in the past. We did a study using Biolox Forte against metal on standard polyethylene, and after 15 years, there were no revisions in the ceramic on poly, and there were 3 revisions in the metal on poly. What this suggests is that if you're using conventional polyethylene, a ceramic bearing or a ceramic head absolutely makes a difference. But again, this was with conventional polyethylene. Now I'm going to show you my experience using large ceramic heads against highly crossing polyethylene with a minimum of 10-year follow-up. The bottom line, the wear was almost identical in both groups. In fact, it was a magnitude less at 0.022 millimeters per year. It's so low, in fact, that it's very difficult to measure the wear, and you can get very confusing data with negative values. But the reality is, at 10 years, ceramic heads did not offer an advantage with regards to wear using highly crossing polyethylene. So I'm not selling it as a wear reducer in the first decade. One of the main reasons I use it is to avoid this problem, which is corrosion due to trunnion problems and elevated metal ion levels that can come from using a cobalt chrome head. This is a devastating problem that is nearly impossible to restore this patient back to normal function. So it's catastrophic, and it can occur very early, in a few weeks to months after surgery. So I don't like the idea of risking this condition in even an older person because it could be a devastating issue. And one of the other issues, I don't want to go into it, I don't have the time, but there's no question that ceramic heads offer scratch resistance, which is very important. If you get a dislocation, your ceramic head will not scratch. And there have been numerous reports now that have shown if you use ceramics in your total hips, there are decreased dislocation rates and decreased infection rates. But let's go back to the metal ion issue. I can show you a prospective study that we did measuring metal ions in patients that had both ceramic and large metal heads. 56% of patients with metal heads had elevated cobalt levels, as well as elevated chromium levels. Nobody in the ceramic group had elevated cobalt levels. So metal heads result in higher metal ion levels, and no patient with a ceramic head appears to have elevated metal ion levels. So you can mitigate this problem if you use ceramic heads. So as a discussion, the wear rates are exceptionally low, and I've documented wear rates as low as 0.018 millimeters per year. We have no concerns for metallosis, no concerns for adverse local tissue reaction. We have not seen ceramic fractures, no noise, and no osteolysis, up to even 15 years. So as a result of these studies, I use 32 millimeter and 36 millimeter ceramic heads in all of my patients. The only issue is cost in my mind, and because of the volume that even Thorsten described, that issue is coming down. Just to give you some more data, you can see the ceramic head usage increasing with metal and ceramicized metals decreasing. This is the American Joint Registry. Over the last 5-6 years, you can see, again, metal head usage going down and ceramic head usage going up. So this is a common trend in all registries and in all parts of the world. So in my opinion, ceramic and highly crossing polyethylene is the new gold standard bearing for total hip arthroplasty. And I use it in everyone, regardless of age, the very, very young, as this debate is about, and the very, very old. Thank you very much.
Thank you very much, Amar, for this very, very clear statement. And now I'd like to ask Vijay to tell us your opinion about bearings.
Thanks very much, Thorsten. I'll just share my slides. Yep. Can you see my slides?
Yes.
Yeah. So thanks, Amar, for the very nice talk. Enjoyed that. So my thing is to talk on the ceramic on ceramic, and this is the debate. And you can see who is Amar here. Yeah, that's very clear. Right. So this is Thurston Gerke. Now, why am I putting the moderator's photo here? I believe that if you put the moderator's photograph, usually tend to win the debate. No, I'm just joking. Is very frequently, Thurston says, there are 3 landmark breakthroughs in hip arthroplasty since the age of Charnley. And they are trabecular metal, cross-linked polyethylene, and taraxamic acid. I think there's a great statement to make, and I think it's very true. If Thurston says something, it must be surely true. So there's no question, as Amar outlined, that the cross-linked poly has been a fantastic advancement. It's been a generational change from conventional poly. Osteolysis has been dramatically reduced. There's no role for conventional poly anymore. We, of course, all agree on that. But the question is, if cross-linked poly is so good, is there no role for any other bearing? That's the real issue that we want. I have to state now that my workhorse bearing is ceramic on poly. However, there are indications in which I use other bearings, and that's really the focus of my presentation today. So Amar said that he uses only one bearing for all comers, which would be ceramic on poly. Well, hip pathology is a spectrum, you see, and we tend to, especially in Asia, operate on very, very small patients. So we got a large number of children on whom we do arthroplasties on. And on the other end of the spectrum, you have the superactive male patients. Andy Murray had a hip resurfacing recently, and he participated in the French Open. I'm sure you can't participate in the French Open with a ceramic on poly. So the spectrum, there are indications in which you have to employ other bearings. You can't put the ceramic on poly on all comers. So that's really the point. So this one-trick poly or pony will not work in all patients. So this is my series of hip arthroplasty in teenagers, 83 so far. And you can see a lot of them are 15, 16, youngest being 11, 12. So we are getting a lot of referrals for these. And obviously, you know, we're not talking about decades, not as Amar said, we're not talking about 10, 15 years. We're look at decades in the future. Then you probably have to think of something else. So when we take on these very young patients, we got to ask this question: are you violating the golden rule of elective surgery? Do the risks of operating on these very young patients outweigh the benefits? We have now 3 tools, I think, that has given us the power to deal with this difficult situation, making the benefits actually outweigh the risks. And these are, number 1, delta and delta ceramic bearing. Number 2 is this larger technology giving function. I will go into all this. And third is a bone conserving philosophy. Now, all 3 of this are connected to the delta and delta bearing. Now, why is COC important when you have this large head concept? Now, one of the slides, Amar did say that all his bearings are either 32 or 36. That's true for the Caucasian population, but unfortunately not true for the Asian population. I'm sure Nico would agree with that as well. So how big do you want to go? So, you know, I also don't use 28 anymore. We go till, you know, 36 usually, sometimes 40, beyond which it's of no value. It's been well documented that is you cross a point of diminishing returns. No point increasing your head beyond 36, 40. So we want to go. So that's the cutoff mark. Now the modern nomenclature for femoral head size would be 22, 28 would be small heads. 32 would be medium or large. It'll be a large head in a small sized acetabulum. It'll be a medium head in a large sized acetabulum. 36 is a conventional large head. And 40 with elderly patients, we tend to use an extra large head. The jumbo metal on metal THR is extinct and should not be part of any discussion now because not being manufactured like the conventional photography film, so should not participate in any. Now, is dislocation still a problem? Oh yeah, it is. This is the recent data from NJR UK, and the second most commonest reason for why they would revise their hips would be dislocation, just next to aseptic loosening. And here's a paper from UK again saying that the increased femoral head size will give you more stability. Another paper from India, IJO, showing the same cause. I think nobody agrees with that, and Amar also agrees with that. Now, we all know about the jump distance, but what we really don't know about much is this intracapsular dead space. So when you use a small head, 22, 28, sometimes even a 32 head, the head can dislocate within the capsule. This is the intracapsular dislocation. So you may close your capsule with the 5 bond or whatever you want, or fiber tape or whatever. It doesn't make any sense because it's going to be intracapsular dislocation. Closing. However, if you have a bigger head, you find that you cannot have an intracapsular dislocation, and that's where the real role of head comes in when you have a thing. So here is a patient whom I have done my reduction, but still I'm able to put the same size head. Small head, you can put that, yeah, before closing the capsule. So what this got to do with ceramic or ceramic? Problem is one needs to have minimum 52 millimeter socket for be eligible for a 36 head. So I'm sure I'm not eligible. It being an Asian, I'm sure all the panelists or all Asians are not eligible, at least most of them. So 75% of Asian male patients are not ineligible for the 36 head. Virtually all female patients. So Amar's argument that he does 32 head would not hold good in Asia because we are operating on 42, 44 size. And what do you do for those patients? That's really the issue. So this is the Asian paradox. We have very small established size, but we need to have a very extreme range of movement for the cultural context. And that's really is the problem that we face in Asia. So we have ceramics and ceramic bearings, which now allow us to do that. So if we see these bearings, small 42 cup, you're able to get a 32 head, 44, 32 head. So I'm able to avoid a 28 head, which would cause dislocation. And I'm able to go either a medium or a large size set. And that really is the role of delta motion in Asia. And you can see I've done multiple cases like that, all with function. And you can see the size of the head in my palm, extremely small sockets. And with this ceramic on ceramic technology, we're able to get either a medium or a large head inside. And that's a critical difference for these patients because we're able to restore their normal lifestyle. Now, Amar said, where is not a problem? Where is may not be a problem for 10, 15 years. But what about the decades to come? Now, Fisher described the same thing that Amar talked about, that if you have less than 0.1 millimeters per year, it won't be a problem. Now, volumetrically looking at it, the magic number is 38 point. Yeah, volumetric analysis. Now, if you have an increased head size and a thinner poly and a higher activity level, that is the equation that you're going to see where in the crossing poly in the coming decades. You can only push a thing so much till it breaks. If you push crossing poly, it's only a matter of time, matter of a few decades before it breaks. No question about that. So wear reduction is great in the crossing poly, no question about that. About 73 to 87% wear reduction. So you may get 2 times, 3 times conventional poly, but this is still inadequate for a very young patient. So now a lot of reports coming up. When you use a thin poly, bigger head, we said is very essential today. When you use a bigger head, you have to use a thinner poly, especially in small sockets. And then you have a lot of reports coming in with breakage of crossing poly. And here's one with the annealed poly. Again, same issue, thin poly problem. Here's another one, same issue, crossing poly problem. So if we go to the next point of longevity of ceramic on ceramic bearings. Now, we're not talking about 10 years or 15 years anymore. We want to know, is it going to be 4 decades or 6 decades? That's what we're talking about. And that, I think, really the role of ceramic on ceramic comes. And here's a very interesting paper. It shows that ceramic on ceramic with fewer dislocations and muscle degeneration by preserving the muscle progenitors. So there's no question that the wear is much less in ceramic on ceramic when compared to ceramic on poly. It'll take a few decades for it to manifest. And that's the reason for all this lower infection. I disagree with Amar that the lower risk of infection in poly with ceramic is not because of the crossing poly or the ceramic, but because of the low wear rates in ceramic on ceramic. So here's the paper, 10 years, absolutely no revisions, ceramic on ceramic bearings. Now, typical patient of mine, 17-year-old, like Thurston showed, I would use a large head ceramic on ceramic on these patients because I'm looking at 4, 5, 6 decades of longevity. And that's what I would do, a delta motion on them. And then, of course, they can do all their functions. Another patient, this patient is only 12-year-old, idiopathic condylosis. And again, I've done a ceramic on ceramic. Now, when you have the functional scores, the HSS is not sensitive enough to bring out the functional level in these patients. So we tend to have what's known as the Asian hip score, in which we have the ability to kneel, ability to sit on the floor, and ability to sit cross-legged. And then we find that most of our patients with this big and medium heads are able to do that. Now, Amar did talk about the squeaking in the ceramic. We'll come to that in a minute. Ceramic breakage, as Amar said, is a non-issue today. And today in 2020, if at all there's going to be a ceramic breakage, liner breakage, it's going to be because of the mal-seating of the liner. Otherwise, there's not going to be any breakage, 2020, with delta ceramics. And you can always see in the pre-op, in the post-op film that the surgeon has not seated the ceramic well. Now, our experience, we have done 919 ceramic on ceramic bearings so far in 2011. We have had no fractures, no dislocations, no infections. 2 patients reported noise. I'll show them. one patient with persistent groin pain, one with probably lack of cup osseointegration, no cup loosenings, and one cup not delta motion cup not bottoming out. Now this is the patient that's squeaking. This is first the top is a patient from Pune. She's that is a very small patient. You can see that 42 delta motion cup, 32 head, number 6 chorale, and she had a transient squeaking for 2 months. After which both of these patients were yoga practitioners. The next patient was from Canada, and then you can see that that's the posture. She still continues to have squeaking in some postures, and when I asked her to send a photograph on when does it squeak, that's the posture. You can see here. That's the posture she is when it starts squeaking. So extreme range of mobility is a possibility, but it's not been a clinical problem. So competent positioning is the key in hard on hot bearings. You want to get, I always talk about this parallelism between the acetabular and the femoral head. If it is there, then probably squeaking will be a non-issue if you employ hard on hot bearings. Now, PGI, Amar did mention about that, and we see that ceramic on poly, you can see that it is good, but ceramic on ceramic is the best. Now, more and more papers, PHYSIO has published a lot as well, that we are going to see more in future if we use ceramics, that in the coming decades, it's just a function of the wear debris. More the wear debris, the more the chance of infection. The less the wear debris, the less the chance of infection. So you'll find that ceramic on ceramic is going to score over ceramic on poly in the coming decades to come. You can see that very clearly in this data. Now, another very interesting, more recent data is that we find that that's low for ceramic on periprosthetic fractures is low. Now, this may be very surprising, and people may laugh at this. This is how we were earlier on with regard to the infection as well. Now we seem to agree that PGA is less with ceramics. Now we see this paper. There's only one periprosthetic fracture for a ceramic on ceramic, but it's very high for a ceramic on polyethylene. So as Amar said, cross-link poly on ceramic may be good for 10, 15 years, but you're looking at problems down the road. So in young patients, I think it's a great idea to go ceramic on ceramic. Now, what about bone conservation and ceramic on ceramic? Now, of course, we have good implants on the femur. So even when you operate on very young patients who are 12 or 13 years old, we have a game plan for the rest of their lives. So I always call it the 2 bites of the cherry. So you use a low profile taper, and then you can have 2 good shots at revisions. Should they fail decades down the line? First time you use a S-ROM type stem. Second time you use a good diaphyseal stem. You get 2 bites of the cherry. But now we have got 3 bites of the cherry. That's really reassuring. Ceramic on ceramic, especially one particular model, the Resurf, seems to be doing extremely well, and reports coming in. And here again, we find that in young patients, small socket size, etc. This opens a new chapter in the hip reconstruction of children. It truly does open a chapter in the reconstruction of the young patient. Yeah. Now this is the new design we're talking about. Resurf seems to have very good wear data and seems to be very, very promising for the years to come. So in conclusion, I want to say, so that's Amar with this one-trick pony or poly, as you want to call it. And then that's me. I think you need to have an a la carte approach. So ceramic on crosslink poly is my workhorse bearing, no question about that. However, when I have a very young patient, especially the small socket size and a high activity level, I would go ceramic on ceramic. In superactive male patients or professional athletes, I would go metal on metal with the Birmingham hip. And in anyone who has got a higher chance of dislocation, I would do a dual mobility hip. So I think this is a more practical way of doing things rather than sticking to one approach, have an a la carte approach. So thanks very much for the opportunity. Thanks very much.
Thank you very much, Vijay. Great talk. I mean, very convincing, very clear, very subjective. So the goal and the duty of moderator is always to make this debate a little bit more objective, and I try to do my best because, of course, everybody has his own preferences. I, of course, as well. So our main choices you can see here. Let's try to make it a little bit more objective by looking at bigger data, by looking at registries, for example. And here for the Dutch arthroplasty registries with more than 200,000 patients, they reported a 9-year, of course, follow-up lower risk of COP and CLC compared with traditional metal on polyethylene, but that's clear in the meantime. And they reported also that the ceramic on polyethylene, of course, is trendy. There's an increasing trend to use it, and it is, at least in Netherlands, and most frequent used bearing. So, and you mentioned it, Vijay, the risk of PGI. Here's a systemic, in my opinion, the biggest systemic review and meta-analysis about the infection rates, PGI rates, by comparing all the different bearings. To be honest, they found in this big meta-analysis no evidence that bearing choice influences the risk of PGI, except metal on metal, what you in some cases still use. So in the consensus meeting, we came to the same conclusion, and we came up with a recommendation that there is a higher incidence of PGI with metal on metal. So that's clear. Every bearing has strengths and weaknesses, and we have further already that the weaknesses of ceramic on ceramic bearings are noises and fractures due to malpositioning. We have also heard that the main risk factors for squeaking, for example, are component malpositionings, the stem design, the cup design, some kind of impingement, loss of lubrication, and due to some papers, BMI. So, but all the big series, like your series with more than 900 patients, shows a very, very low risk of fracturing. Here, the paper from Argentina, almost 1,000 patients, just one line of fracture and one femoral head fracture. Today, it's clear that Delta ceramic, of course, has a much lower fracture rate than the old Forte ceramic. But if you compare, and that's the goal of this webinar, COP versus COC, then we came up with the conclusion that probably they are not different in total, because ceramic, the New Zealand Joint Registry showed that ceramic on highly cross-linked polyethylene had the lowest all-cause revision rate and superior to all other, including COC bearings. And highly cross-linked PE seems to be one of the best, as we heard from Amar already. And this is a very nice paper. We have some nice papers and slides, because even if you have a very small thickness, thin thickness of the polyethylene, you must live more than 116 years with the prosthesis to develop some problems. So especially, and let's come back a little bit to our main topic, young patients. So here, of course, ceramic on ceramic works fantastic in very young patients. This paper from Korea shows that they had a survival rate of 6 years of 100%. Another paper from Korea, 100% after 10 years in patients lower than 30 years. But if you look at the whole literature, you cannot find really a significant difference regarding ages, regarding outcome, regarding risks between COC and COP. All these papers reported similar results of COC and COP. And especially also in patients in young patients, and that's a very interesting paper. Mean age was 45 years, where they did bilateral, one side ceramic on ceramic, the other side ceramic on polyethylene. And as you can see, the clinical and radiographic results of using COC and COP, highly cross-linked bearings, were similar. So in total, no difference in these patients who received one on the other side and the other one on the other side. So our philosophy, at least here in Hamburg, is regarding fixation, younger than 75 years cementless, older than 75 years hybrid, of course, cementless cups. And regarding we always using highly cross-linked polyethylene, but in younger patients, younger than 75 years, Biolox Delta and in older patients, is a much cheaper Biolux Forte or even metal if the patient is over 80 years. So to conclude and to try to make it a little bit more objective, at the end, it seems that the results are the same, or let's say similar, with little differences. COC is less forgiving than highly cross-linked polyethylene. Metal on metal, of course, seems to be obsolete, and we use always, as Amar does it in every patient, ceramic on highly cross-linked patient, at least in all our patients younger than 75 years. Thank you so much. And now I'd like to open the panel discussion. First, I'd like to ask all our panelists, to be honest, what kind of bearing do you use in your daily work? Or do you have the same philosophy like Amar to use ceramic on poly or COC in all your patients, or you are more differential like Vijay? I'd like to ask our main host, Parag, how are you doing it?
So I'll pass the question to Dr. Joshi, who does more hips at Sancheti.
Okay, Dr. Joshi.
Hey, if we are doing it in a younger patient, my preference is ceramic on ceramic. Anything above 55 years of age, I would go ceramic on poly. Hardly using metal on poly.
Your cutoff is 55 years.
More or less 55 and activity of the patient. We feel that around 55, the activity of majority of Indian patients slightly decreases. They are nearing their pensionable age, which is around 60, 58 in some people. And after that, they do decrease the amount of activity they have. So I would go for less than 55, mostly a ceramic on ceramic. More than 55, it would be ceramic on poly.
Mahesh?
Rita, you also mentioned that you differentiate, you're differentiating between in the ages. What is your cutoff regarding age, Vijay?
I would say less than 30, I would go ceramic on ceramic. And after that, I would go ceramic on poly.
Okay. Parag, you wanted something to say.
I wanted Mahesh to comment on his bearing surface preferences.
Okay.
Yeah, my preference is ceramic on poly for most of the cases. However, there are some patients who are well read or have been convinced by other surgeons to go for the more expensive bearing, which is ceramic on ceramic in our country. And they feel whatever is more expensive is probably the best thing to happen to them. So they have the money, so they will demand to have a ceramic on ceramic. But I would stick to ceramic on poly being my choice of bearing for nearly most of my hips.
Sayed, what's your opinion about it? Do you have a cutoff?
Young patients who are active with good bone stock, I'd prefer ceramic on ceramic. But in a complex primary situation, even in a young patient, because ceramic on ceramic is less forgiving, in those cases I'd be biased towards ceramic on poly.
Mm-hmm. So Mahesh just mentioned the costs, and you did it as well, Amar. Do the costs play a big role in your decisions, Amar?
Yeah, I mean, in our system, no. The patients don't have to pay for their implants. So I don't think cost is a major issue. Certainly the cost of revision surgery is very high. So any minor cost that you pay upfront to mitigate revision, I think is probably worth it. You know, I think one thing that we need to be careful of is we talk about ceramic on poly, we talk about ceramic on ceramic, but we can't take that out from the implant design. So on the ceramic side, I think we would all agree that it's Biolux Delta, which is what we're talking about, and every company is using that. But on the poly side, there are different companies, and there are different manufacturing techniques and different, results. They've all performed relatively well, but there could be an issue there. In the history of ceramic on ceramic bearings, many of the long-term studies had problems with fixation. They weren't necessarily problems of the bearing. So that makes it a little difficult to interpret. But I think sometimes we get too general in talking about things when we need to get very, very specific. And then my last point would be the reality of the situation in the US is there is no ceramic on ceramic device available. So that makes it a lot easier for us to decide.
Yeah, I'd like to, on the same point that Amar raised, very important point that we all put the cross-link poly into one basket. There may be, recently there was a report about the Exatech, right, from HHS. So you don't know. So the question is, each company says obviously their poly, cross-link poly is the best. Now, when will we know this, which is the best? 15 years, 20 years? And that really is a problem. Whereas in ceramic on ceramic, we all agree it's going to be from CeramTech, no matter which company that you use. We said the head is also going to be from CeramTech. The line is also going to be from CeramTech. So you are sort of insured in that way. We're not sort of having a lottery, as you know, we'll wait for 15 years to see whether that company's crossing poly will work or will not work. So here is an insurance against, especially in very young patients.
But again, Vijay, I think the fixation of ceramic liner inside the cup differs amongst companies as well. So if you take, say, Smith & Nephew, you got a metal ring around it, which can cause issues. The tapers for the ceramic on the outside are different with different companies. So there is again
sure, yeah. I take your point, but these come out very early, yeah. So for example, the Smith & Nephew, the metal liner has been withdrawn. These are early problems. Whereas the cross-link poly, as Amar said, most are good. So you will get to know later on. You will get to know only at 15 years, and that's the problem that we have.
I'm not fully agree with you, Vijay, because here, at least here in Germany, we have 4 different manufacturers for ceramic, 3 beside of CeramTech. So there are probably some differences, and there are coming up new companies on the market who are producing ceramic as well. So Rajiv, you are a hip specialist, and Rajesh, and Rajiv, what are you doing in case of a complication? Let's say if you have a liner fracture or a ceramic head fracture, I mean ceramic liner, what is your procedure? What is your philosophy to solve this problem of ceramic fracture?
Well, to be frank, I have not seen a single ceramic head or a liner crack at present. I've seen one case who had a liner crack, but it was very difficult to tell him that you get it done. It was done somewhere else in Mumbai, and he came to us and he said that he feels a little funny in his hip, and took the X-ray. You could see the particulate matter all around the hip. But however we tried to convince him, he was quite asymptomatic in the sense that he would get a click once in a while, but he was comfortable walking around and he didn't come back to us. But if I had to revise it, then probably you use an option head, and I would go again with this. That time I would probably go in with a ceramic and ceramic again, and make sure that the liner is sitting much better than what it was sitting previously. I very much believe that the reason for squeaking and the reason for fracture, both are going to be a bad alignment between the basic shell and the liner which you're going to put in. And the squeaking is, I feel it is more like a point load when the cup is very open book type of a thing, and then, or in a case in which you have done it through a very, very small incision and the whole thing is tight in itself. Those are the cases, like if you have an old excision arthroplasty or something and you try to put in a ceramic on ceramic and that thing squeaks on table. I mean, if you put a liner on and just put the trial liners on, even they squeak. I've seen it in one case and I had to go back from putting a ceramic on ceramic to ceramic on poly, but that was only one case in which I did, because we had to bring down the thing and the whole thing was such a tight fit that it squeaked. Till now, we've done something to the tune of about 300 plus cases of ceramic on ceramic. We are nearing around 7 to 8 years of time duration in 50% of those cases. And I've had one case who squeaked for some time and it disappeared on its own. I don't know why it squeaked, but that was happening when he was bending down and then bending his knees and trying to get up from that position. Sometimes it would squeak for him, but he couldn't demonstrate it to me. So I never really saw any case of squeaking also.
Amar, how many patients with squeaking have you seen in your career, and how many ceramic fractures have you seen? And how did you solve it?
So I've seen no ceramic head fractures with Biolox Delta. I have seen many Forte head fractures and many Forte alumina liner fractures. The squeaking, I think a lot of the squeaking also, to my earlier point, was design related. There was a Stryker version that had a much higher incidence of squeaking than other designs. And it may have to do, Dr. Walter in Australia thought that the resonance of the metal, the TMZF metal, may have influenced the amplification of the sound. But it's no question, regardless of design, squeaking does occur with a ceramic on ceramic hip. And it's a low rate. It's certainly not a very high rate, but it's a very uncomfortable thing for the patient. The other thing, you were describing all these patients who were putting their hips in extreme ranges of motion. I think poly is much more tolerant of extreme ranges of motion and impingement than a ceramic on ceramic bearing. So I would be careful of allowing your patients with those ceramic on ceramic bearings to achieve those levels of range of motion.
What's your solution in case of ceramic fracture? What bearing do you use in revision?
So we published on that because we did use Forte for a while and we saw some fractures. I think the key is to do a thorough synovectomy. So I will go, I usually do a posterior approach, but from the same incision, I will do an anterior dissection and basically an anterolateral exposure, and then make sure you remove all the broken parts. So the synovectomy is the most important thing. Ideally, then, putting in another ceramic and ceramic bearing would be the best thing to do. Most of those patients, however, are hesitant to do that. So what I do nowadays is I put in a ceramic head delta with a titanium sleeve, and I'll use highly cross-linked poly, but make sure I do a thorough synovectomy.
Sahil, are you doing the same? Ceramic on polyethylene in revision of ceramic fracture?
Yes, pretty much the same.
Vijay?
Yeah, I agree with Amar. In about 2010-11, there was a school of thought that you must use only ceramic on ceramic for. I've handled a lot of them. I get a lot of referrals for them. That you must use only ceramic on ceramic in the revisions. And as I think Rajiv said, certainly I will not retain the cup if I'm doing ceramic. I mean, I'm talking about a decade ago. We used to revise the cup and then do a ceramic on ceramic. But now after Ranawat published this paper, we are confident of using poly. And sometimes, with a hooded poly, etc., you may be able to get away with the same cup. And we do a synovectomy, as Amar said. And touch wood, we haven't had any issues. We, of course, never use a metal head. It's always ceramic head. We have not had any problem in using a ceramic on poly bearing for a ceramic fracture so far.
Okay. Sahil, we are talking all the time about ceramic on polyethylene, but there are existing still some old polyethylene cups. How often do you use, or do you differentiate, have a differential therapy between highly cross-linked and the old polyethylene, which is not highly cross-linked? Do you use it sometimes? I mean, for example, due to the costs?
No, we're only using highly cross-linked polyethylene, not using the old one at all.
Okay, Rajiv, same in Pune? Rajiv?
I have not used the old poly for a long time, in 20 years.
So everybody is using the highly cross-linked polyethylene at the moment, and I think that's a good choice. So to summarize it a little bit, there are many different cutoffs between in the age groups. Ceramic by using ceramic on ceramic. Vijay said his cutoff is 30 years. Rajiv said his cutoff is 55 years. So, and Sahil, do you also have a cutoff?
About 35 to 40.
35 to 40. So there's a wide range okay. Are there any questions from the panelists? Yeah, Sahil.
Two questions. First thing is one of the most common questions were asked by the patients in the OPD, and that is when we tell them about the bearing surface, they often ask, how many years is my hip going to last? So I want to know the answer of all the panelists that what do you say for COP or for COC? And the second part of the question is, does your cup positioning alter with your choice of bearing surface? Would you want a more closed book cup with ceramic on ceramic to avoid edge loading or impingement and those issues? Or what's your target cup inclination and version?
Mahesh, would you like to answer these questions?
So there is a good paper from Lancet about the longevity of a hip replacement, which has been published, which I routinely use in practice to tell the patients about how long are they going to last. So I think it says about 85% last for at least 25 years, if I'm not mistaken. And the second question was about the inclination of the cup. With highly cross-linked polythene and ceramic, probably you wouldn't make much of a difference between changing the orientation of cup. I would treat both of them pretty much in the same fashion, because the highly cross-linked poly is as brittle as ceramic.
So your target inclination is?
So the target inclination.
Inclination?
Yeah, I would close the cup more than the standard teaching of 45 to 50 degrees of inclination. So the cup will be more closed in the case of both of these bearings.
Amar, what are you saying about longevity and positioning?
Yes, I would agree. I say 25 to 30 years. And for the vast majority of patients, that is certainly more than enough. As I don't do ceramic on ceramic, I don't alter my positioning for the cup. But I want to make a point that I think often gets overlooked. We talk about an age cutoff for using a different bearing. But the most important thing when we do an arthroplasty is not the bearing. It's not the alignment of the components. It's fixation. And if you use a different system because you want to get that ceramic on ceramic bearing in a young person, and a system you're not as familiar with, the reaming can be a little different, the broaching can be a little different. If you fail on fixation in that young person, you have totally failed that person. So I think that's the key, is make sure you get good fixation, and whichever bearing you use, you're going to give that person probably 20 years of pain relief. And by any measure, that's a good deal. But don't fail on fixation.
Mahesh?
I have a question for Vijay. As Vijay mentioned that in Indian patients, the socket size is very small, and he prefers to use a monoblock cup, which allows us to use a bigger head. Vijay, do you think a dual mobility now is a good option as well for these younger patients, or we still a little bit suspicious of the long-term outcome of dual mobility vis-a-vis a ceramic on ceramic with a monoblock cup?
Yeah, we don't know about dual mobility in young patients, although a lot of French literature says it's okay. I'm very skeptical about it. Yeah, so you can't have everything in life. There's a give and take always. And so I'm very skeptical in using dual mobility, especially the one with the liner that you put in young patients. I'm very happy to use them in elderly patients, dislocation, etc. But I would be very skeptical in using that. Yeah, I have used Forte on Forte. My own experience now, 18 years, I have patients. Now the difference between conventional poly and ceramic on ceramic is that in conventional poly, on 20th year, it didn't fail like that. You could see the failure on the X-rays going down like that. Yeah. But here you have a 20-year X-ray, which is pristine. It's not a fail, it's pristine as day one. And that's why I'm much more optimistic about longevity of hips, whether even cross-linked poly or ceramic on much more than 20-25. That's very conservative in my opinion. Because we have not seen that, a ladder that's coming down a slippery slope. It's like day one X-ray. So I'm much more. And then fixation has been solved to a large extent, I think. Fixation, unlike cement, which is just a time clock waiting to fail, a non-cemented process just doesn't fail in that mode. So somebody has to invent a new failure mode for these to fail. We're just interpreting conventional poly, superimposing our concept on this. So I'm much more optimistic than your values. But I'd like to make one philosophical point. Now we have ceramic on ceramic, we have ceramic on cross-linked poly. Now you can cross-link more and more and get wear resistance. but you are going towards the ceramic side. The more cross-linked poly is going to behave just like a ceramic. It gives the ceramic properties. Yeah. So it's a give and take. Do you want wear, or do you want a bit of fracture problems? And so it's like that. So cross-linked poly. If you don't cross-link so much, you will get much better longevity than conventional poly. Is very safe for your extreme actions, etc. Safe, but then you have to pay a price for the longevity. So it's a give and take there.
And your target cup inclination?
Well, I'll go native in all the patients, like the X-rays that I showed. It's in the region of around 40 to 43 degrees. But I would go native for that patient based on the transverse acetabular ligament, and I'll ignore whatever is the superior landmark.
Thank you so much. Rajiv, any comment about it? What are you saying about longevity of your implants?
Longevity is something it is very difficult to really comment, and that depends a lot on how good the patient is going to really do his exercise in the end, or how active it's really going to be. The problem is, once that pain goes away, I've seen a majority of the patients land up putting on a lot of weight, and not only putting on a lot of weight, they decrease their outdoor activities per se. Somehow, it doesn't make sense, because now it's not painful, they should be going out. But a lot of them don't do. They are so stuck up in their job or something, they're putting on weight, the muscle strength is going down. And these people, somewhere or the other, the bone stock starts dwindling. And if that happens, and then subsequently, if there's going to be any injury or something, a micro crack somewhere, and then you can start getting a problem. So I'm not sure of that. I tell them your joint in the bearing per se can last you a lifetime, whatever you're going to use. But that's not enough. You have to do some exercise, make sure you're fit, make sure your weight is under control. And Dr. Vijay allows them sitting on the ground and everything. I'm very scared of allowing them. Because it's like, if you allow them that, then the next thing you know that I have a patient of mine, he is a young person who's in police service. So his wife rang me up once and says that this fellow went chasing after some person who was running away, and then he kicked open the door. He's got a unilateral ceramic on ceramic. He kicked open the door, went inside, caught him. So please tell him not to do such things. These are, you're putting that. In the end, it is an artificial joint. It is not something which is nature which has given you. It has no healing potential. Even if it cracks somewhere or something loosens out somewhere, it is going to become more and more with time. And with majority of the patients, they don't understand that when you're looking at an artificial thing, you're looking at something with a little bit of restriction. I would tell all my patients that, when you're taking a hip joint replacement, that's your girlfriend. It's not a wife. I mean, an Indian wife, even if she's mad at you, she'll still feed you. But this is a girlfriend. You don't listen to your joint is going to screw your happiness really left, right, and center. And majority of them do understand that.
Very pessimistic. Can I just comment on that? Very pessimistic view, Rajiv. When there's, earlier people used to say it's artificial, so it can't last forever. Forever doesn't mean millions of years. Forever means only the longevity of a person. Now, assume we find a material which lasts for 100 years. That is forever. Now,
yeah, for his life,
that philosophical statement, nothing lasts forever and all, it's okay, but you must interpret it within that. So it won't last for millions of years, but we are not going to live for millions of years. So that way, it may be an everlasting solution. Similarly, have you seen any problem with your patient doing any activity? I have not seen in 20 years. So what are you saying? You should not restrict them. I know now why your patients are not active. We already told them not to be active. That's why they're not active. My patients are very active.
Okay. So last but not least, I've forgotten to ask you, Mahesh, what is your differential therapy, or do you have a differential therapy in treating the patients? Do you all treat all the patients with COC or COP? Or
Yeah.
Are you using like still metal on metal bearing surface replacements?
Now, personally, I am not using any metal on metal or surface replacements. I use oxidized ceramicized metal in a few of the cases, along with the implant of choice if it belongs to that company. Majority of my cases are ceramic on poly, unless the patient is aware of the bearing options that is present and he demands for a ceramic on ceramic bearing specifically.
I'll just make one point, Thurston, on this ceramicized metal. The reason I use a lot of them is that in our Asian patients, our offset is so low that the ceramics just not manufactured those minus heads, you know.
Minus heads, yeah.
So in those patients, if you put this head, they are so uncomfortable. You increase their offset, they have trochanteric pain, etc. In that case, the ceramicized metal really is helpful in that situation in Asian patients.
So thank you all so much, because our time is
one last question, Thorsten.
2 minutes, and I'd like to hand back to our host, Parag.
Yeah, so I'll just ask the last question before we end to Amar, Vijay, and Thorsten as well. What do you see in 10 years' time, Vijay, Amar, and Thorsten, the bearing surfaces being? Will be the same what we discussed? In the younger, you go for ceramic on ceramic, elderly, you do ceramic on poly. What change do you see 10 years from now? Vijay?
Well, we first need a problem to solve. So as I said earlier, you know, we're trying to impose our concept on conventional poly on these. So we seem to have solved fixation with non-cemented both sides. We seem to not wear to a large extent. So, you know, we currently don't have, and if you are able to use bigger heads in smaller patients, you solve dislocation also, provided you know how to put your components. So I don't see any point in trying to solve a problem that you don't have.
No, but
it will be the same.
Yeah. Changing the bearing surfaces 10 years hence. So
why do you want to change it? Yeah, there's no problem to solve here.
To go for longevity from 30 years to 40 years.
We're already very close to it, I think. Yeah, we're already very close to it. Yeah. Okay. And then, as I told you, conservative revisions, we have, I mean, to test a new bearing will take 20 years. So that's the reason why if something lasts for 5 years, I'd go for it. Yeah, I mean, in the sense to test it. Yeah.
Got it. Amar.
Yeah, I mean, I think, you know, technology always marches on. And there's always a push from industry to try to create the new thing. However, the problem is, as Vijay is describing, the hip is a nearly perfect operation. Nearly perfect. The odds of you making the operation better with a change is exceptionally low. The odds of you making it worse with a change, and that's one of the reasons why I don't like dual mobility, is much higher. So I think change in the hip replacement field should be taken very, very cautiously. And I expect in the next 10 years, there to be not much difference in what we're doing today.
Okay. Thorsten, your concluding remarks.
Yeah, almost the same here. To be honest, we are talking about a procedure which is now 60 years old, and regarding material and bearing, something of course has changed here in the last 60 years, but nothing dramatic. So I do not believe that in 10 years we will implant some other materials or other bearings. 10-year period is for me too short, and as Amar said, we are talking about an almost perfect operation, and I do not believe that the bearings makes this difference. Our next goal should be to reduce complications, of course, but this has nothing to do with the bearing, in my opinion.
So before I hand, Amar.
Yeah, I mean, I think the changes that are going to come are not going to be in implant design. They're going to be, you know, as we mentioned before, I think Vijay mentioned tranexamic acid, right? That became a game changer. So peri-operative anesthesia, pain management, maybe wound closure, you know, infection mitigation. Those are the things that are going to have the potential for improvement and change, not the implant design.
I agree with that. That's the reason probably the anterior hip has also gained a lot of traction, because there's nothing else to do with the implant. So something has to change. So people went anterior.
I agree with that statement too.
Yeah, so exactly. So before Sahil concludes, I'd just like to end on a philosophical note. I think whatever in orthopedics, we've seen that the procedure, what we do now in 10 years time, it does undergo a change. And we've seen that historically. So I don't know, in 2030, we all will be there. We'll all discuss. I don't know whether Vijay Amar would have to eat their words. I don't know. Let's see. Let's discuss that in 2030.
Look forward to that.
To Sahil.
I'll bet my hair.
That'll come.
Thank you once again. to.
I think we should close this session, wonderful session. I'd like to thank all of you so much because we had a great discussion and great talks from Amar and Vijay. I think it was a perfect overview about the current status of bearings. And I'd like to thank especially my friend Parag and his father, of course, to organize this meeting. And thank you so much. Hope to see you soon.
Thanks, everyone. Thanks again. Great to participate.
Great seeing you all.
Thanks.
Bye, Amar. Bye, Thurston.
Bye, everyone.
Good day to you all.